Dr. Lobel for this very nice presentation. And now I have my pleasure to introduce my dear brother, Professor Dr. Alaa Kandil, Professor and Head of Clinical Oncology Department at Alexandria University, and he's talk about neoadjuvant hormonal therapy in breast cancer.
Okay, Bismillah ar-Rahman ar-Rahim. Thank you, Mr. Chairman, dear colleagues. This is the title of my talk as mentioned by the chair, Neoadjuvant Hormonal Therapy. This goes with the same theme of the session, however, a little bit shift of the gear to use hormones in the neoadjuvant setting rather than chemo or targeted therapy. So, the choice of preoperative and neoadjuvant chemotherapy depends a lot on the patient demographics and the disease characteristics, whether these patients harbor a HER2, triple negative, or a luminal A subtype disease. That makes a lot of difference in the choice of the treatment we are applying. Though neoadjuvant hormonal therapy is there, it's a little bit a forgotten practice in our daily clinical practice, as we are almost used to use systemic chemotherapy in the neoadjuvant fashion, though it's more toxic than hormonal therapy. As we all know from all the trials of neoadjuvant chemotherapy, we are definitely trying to assess the response to a definitive regimen therapy, and also to increase the rate of less radical surgery by downstaging the tumor and ending up with a so-called lumpectomy or a conservative breast surgery. The rationale has already been described. We are trying to first to shrink the tumor. We're trying to induce complete pathological response. And we also have an excellent model to look into the activity of an agent, being a chemo, hormonal, or targeted therapy. Patients are treated de novo to start with. We can have results very quickly and less number of patients and less costly trials as compared to the adjuvant trials. We have also to look into the integration of the molecular determinants of response and resistance, and this is in particular of a great deal of interest in the management with hormonal therapy, as we know about the problem of the primary and secondary hormone resistance that we all face in treating our luminal subpatients. So this mode or this modality of treatment using hormones in the neoadjuvant fashion has a specific particular biologic interest, I guess, for every oncologist in the field. In addition to the benefits and the rationale we know about systemic chemotherapy in the neoadjuvant fashion, hormonal therapy has one major advantage. It's less toxic, more tolerable to our patients, and it also allows for breast-conserving surgery, but just give the patients a little bit more of time, 3 to 4 months, to express this effect and then go for limited surgery. We all know that the response rate from the neoadjuvant therapies to systemic chemotherapy differs a great deal by the molecular subtype. As you see that with luminal subtype, you can have something like anywhere about 5 to 7% of complete pathological response with systemic chemotherapy that goes up to 35 or 40% with triple negative and somewhat in between for HER2 and luminal B subtype. So chemotherapy might not be the real answer in the neoadjuvant setting for patients with luminal, specifically luminal A subtype. We also will go through a little bit of data. We have data that tamoxifen as a single agent, especially in Great Britain and some Latin countries, works a great deal with very good results, as with 72 months of follow-up using only tamoxifen as opposed to surgery or tamoxifen led to a very good overall and disease-free survival. However, using tamoxifen alone in this subgroup of patients will lead to an earlier onset of disease recurrence. So it has to be used with a very great deal of caution, rather to apply it to everybody. Further data for tamoxifen. The rate of breast-conserving surgery has been seen significantly improved as not to have it before the surgery, and that was in the favor of 54% as opposed to 44% data shows in the Annals of Oncology by Moriac. However, in a very small subset of patients, only 200 patients. Whether tamoxifen or aromatase inhibitor, this is a very important question. Dixon already reported a 50% improvement and downstaging of tumors with ER-positive disease, however, with much higher response rate in using aromatase inhibitors, ranging up to 80% in patients treated with letrozole and almost another 78% with anastrozole. There is a little bit of a problem using tamoxifen as opposed to aromatase inhibitors, is that you need a little bit more of time using tamoxifen to reach a plasma level which is quite shorter by using aromatase inhibitor. Now we come to a little bit of more randomized trial, those small ones, but this is another very well-known randomized trial comparing letrozole versus tamoxifen in the neoadjuvant fashion in nearly about 160 patients in every arm for 4 months of time, and then going for surgery, mainly looking into the overall response rate and the rate of conservative surgery and the downstaging applied for that. And as you can see, when you measure that either clinically, by ultrasound, by mammography, there is a shoulder, or there is an improvement, a significant improvement for the use of letrozole over tamoxifen, and you can see that was a significant improvement in addition to increased rate of conservative surgeries in the arm of letrozole as compared to tamoxifen alone. Also, in that trial, the proliferation marker of Ki-67 was measured, and there was nearly 12% improvement in favor of letrozole as opposed to tamoxifen. These are the summary points of the study. 4 months of preoperative hormonal therapy, whether letrozole or tamoxifen, consistently led to higher response with letrozole, and the rate of breast conserving surgery was significantly superior with letrozole, and it was quite well tolerated actually in both treatment groups. There comes the IMPACT trial, which is more or less the same design as the ATAC trial, using or comparing anastrozole, an aromatase inhibitor, and tamoxifen, and the third arm was the combination. We'll forget a little bit about the combination as we did with the ATAC trial. And this is the design of the trial: 3 months of treatment of preoperative hormonal therapy, either using anastrozole or tamoxifen. Good number of patients. This is a little bit of an elderly patient population. As you can see, that the median age is almost 72 years, and an average size of a tumor is something like above 3 centimeters. They ended up with a better rate of conservative surgeries. As you can see, this is per the surgeon's assessment at 3 months. 46% of the patients in the anastrozole arm underwent breast conservative surgery, as opposed to 22% in the tamoxifen arm. This is quite a difference by just applying a single tablet a day, a very simple treatment. However, we have to choose our patient very carefully to have a success rate within this treatment. And again, quite acceptable toxicity as opposed to the usual systemic chemotherapy we apply universally to the majority of our patients. As we all know, that cancer develops because of hyperactivation of certain cellular pathways. So researchers did try to look into a little bit in details of these cellular pathways, and here comes that trial where letrozole was looked into the neoadjuvant fashion and compared with tamoxifen, and that was correlated with the presence or absence of the positivity of the ERB1 and ERB2, and the results was quite interesting. This is a population of postmenopausal women who are ER and or PR positive that was treated with letrozole, the usual 2.5 milligrams daily, versus tamoxifen 20 milligrams. And these are the data showing, again, what we already presented: 60% response rate with letrozole as opposed to 40% with tamoxifen, with a significant difference. Now, they went in and looked into the details of the ERB1 and ERB2, and as you can see, the response, I'm sorry for the quality of the slide, but I will read it to you. In ERB2 positive patients, in addition to being also hormone responsive tumors, the response rate with letrozole was 69% as opposed to 17% in the tamoxifen. Quite a difference, almost 50% difference in response. Furthermore, in ERB1 positive, the response was 42 versus nearly 0 response with tamoxifen. So it seems that there is something about the mechanism of action of tamoxifen versus letrozole in patients who express ERB1 and or ERB2 positivity. And this is some sort of explanation that it might be that the ERB1, ERB2 dependent ER phosphorylation prevents tamoxifen from doing its action as an anti-estrogen, and letrozole X through aromatase inhibition might do the job. Another brilliant and a simple idea is to always try to block more than one, as we do with the HER2-positive treatment patients with systemic chemotherapy. You apply chemotherapy with an anti-HER2 agent, whether one or two, and the usual now in the neoadjuvant fashion is we apply 2 agents, is to apply the hormonal treatment with an anti-HER2 therapy. And this is a trial already presented 2 years ago in the ASCO, published in the JCO in the year 2013. And the trial are giving 2 anti-HER2 therapies, lapatinib and trastuzumab, and the trial included ER-positive patients and ER-negative patients. Just concentrate on the ER-positive patients. They also received a single 2.5 milligram tablet of letrozole daily. And the response in terms of complete pathological response and good partial response was excellent. 21% of the patients who are ER-positive and HER2-positive had a complete pathological response, 1/5 of the patients, which is quite satisfactory, in addition to another 33% of the patients who had a very good partial response. And even if you look into the TNNN, the tumor and the primary node, you have a good pathological response of 18%, again, just by applying 12 weeks treatment of 2 anti-HER2 therapies and 1 single letrozole tablet daily. Whether an aromatase inhibitor, one aromatase inhibitor being steroidal or non-steroidal is better than the other was looked at in that trial, published in the JCO in 2011, and the answer collectively was no, there was no difference in terms of effect when used preoperatively using exemestane, letrozole, and anastrozole in the usual those levels, applying that for patients with T2 up to T4C, N0 to 3, M0 breast cancer patients with a high score of ER positivity, being 6 to 8, tumors more than 2 centimeters, and the results as shown in that. Sorry again for the quality of the slide. Collectively speaking, almost 20% complete response rate and another 40% with partial response rate. This is the breakdown of the response rate. And if we look at the rate of applying conservative surgeries to those patients, patients were to start with marginal for breast conservation, went on and had another 45% of breast conservative surgery, 40 and 48, with no statistical significant difference between the 3 aromatase inhibitors, only numerical difference. So it means that more or less you choose according to the toxicity profile of whatever drug you're using, but the 3 aromatase inhibitors act more or less the same. These are the most common 3 and 4 grade serious adverse events that was presented applying these 3 aromatase inhibitors. In exemestane, joint pain was in 2.4%, letrozole, the hot flashes was 3.9%, and anastrozole fatigue was the most observed side effect in 3.3%. And these are the summary of key conclusions. They all work, leading to a nearly 50% increased rate of breast conservative surgery, and they are all well tolerated together with no real difference. Are we able to identify those patients who should be treated with this less aggressive treatment? Yes, we know that they should be ER positive, but not all ER positive patients are the same, being luminal A or luminal B. Even within the luminal A patients, some of them will show secondary resistance to start with if we do that. And for that, this is I consider a very nice trial that's presented last year in the JCO by people from Edinburgh, where they looked into the molecular profile of those patients they're treating, and they could identify 3 different subtypes within the luminal subtype. Those are not responding, those are slowly responding, and those are really responding or significantly responding. And they looked into that further a little more, and they came up with a so-called 4-gene predictor. And they could really find a correlation between the outcome of those patients in terms of disease-free survival and overall survival. So those patients, if you can identify them with this good molecular profile, can respond better, and then they are applicable for this type of treatment. Hopefully, we see more of these type of tests to get that. Now, last but not least, we need to answer that in a more randomized fashion, which is getting those patients who need this neoadjuvant treatment who are ER positive, and then apply 2 arms. One of them will receive neoadjuvant hormonal therapy versus neoadjuvant chemotherapy, and come up with a result that will tell us which is better. We don't have a randomized trial like that. However, we have, I digged out in the literature, we have very small trial of 122 postmenopausal women with a median age of 67 years who are hormone responsive, having a large operable, locally advanced breast cancer. And they underwent chemotherapy versus hormonal therapy, and the hormonal therapy was either anastrozole or exemestane. Chemotherapy was adriamycin and paclitaxel, and the results, there was no difference. But again, you cannot conclude anything from that study. This is a very small trial, but it just gives you a glimpse that in some group of patients, the results of chemotherapy might be exactly the same like hormonal therapy. And you can see here that the rate of breast conserving surgery or the rate of local recurrence rate is more or less the same, with no statistical significant difference. However, with a major difference in terms of toxicity. As you can see, the long bars, this presents the toxicity of the chemotherapy, and the short wide bars representing the toxicity of the aromatase inhibitor. But you have to choose your patient right, not to deprive her from chemotherapy while she needs it. If she's a candidate for this treatment, that would be fine. Sorry. Okay, so aromatase inhibitor is there. It should be used more or less as a standard of care for postmenopausal women. We don't have guidelines telling us whether we should use this and when and how, and what are the patient's characteristics that we should be applying that. If we could come up with a trial comparing chemotherapy with hormonal therapy, we don't think anybody would agree that the end point at that type of trial would be complete pathological response, as we know that complete pathological response with hormonal therapy is quite low. We're looking at mainly staging and disease control to increase the rate of breast conserving surgery. Thank you so much.